right, everybody. We're going to talk about shoulder ultrasound today. Mostly we're going to focus on shoulder dislocation, do a little bit about blocks for reduction, and then the full exam we're probably not going to get to. If you guys are interested, you can ask me. So we're going to talk about anatomy briefly, some indications, and again, most of this lecture is going to be looking at pictures and diagnosing shoulder dislocation. So here's anatomy. Rotator cuff around your glenohumeral joint is going to be your sits muscles, your supraspinatus, which you see here, your subscapularis, which kind of runs under the long head of the biceps. And then in the back, you have your infraspinatus and your teres minor, which you kind of see here too. Those kind of hold together your glenohumeral joint, which is where your humeral head sits in the shoulder socket.
Point out there's no muscle inferior over there.
Right down here. So that's when our most common dislocation site is going to be anterior, where the head slips under these muscles, compared to posterior, which really only happens in a few cases, and it's pretty difficult to do. Here's a straight-on view of the muscles again. Here we have the supraspinatus, infraspinatus, and then down here we have teres minor, subscapularis. And then just picture a pocket here where the shoulder kind of dips into. All right, so indications, pretty self-explanatory. Any shoulder trauma, shoulder pain with like subacute or chronic injury kind of gives you concern for rotator cuff strain or tear, which you can diagnose on ultrasound, but it's kind of outside our purview. But just know that it is something that either orthopedists or rheumatologists will do on a regular basis. So it's good to know about. And again, we're not going to get to the slides, but just ask me if you're interested. So deformity and going off deformity is going to be analgesia. We're going to look at some studies that say that shoulder injection with ultrasound with just lidocaine is just as good as conscious sedation for giving analgesia and anxiolysis to reduce that shoulder without conscious sedation. So this guy is kind of comparison and comparing sensitivity specificity between X-ray and ultrasound, and shows that ultrasound is just as good, just as sensitive, and has 100% specificity for anterior and posterior shoulder ultrasound. We'll go over the kind of what you're looking for. This study had like a measurement between, we'll go over it, but this is the humeral head here. It's outside of the GH joint. They had a kind of measurement between the two, but as I show you in the next few slides, we don't really need that. You kind of see it, you don't. You're looking for this clear line. But this is a good study, and there's multiple studies that compare X-ray to shoulder ultrasound for diagnosis, and it's just as good. Oh, and this study also said that times are much shorter in the ED, which makes sense because we wait forever for an X-ray. All right, so the approach for shoulder ultrasound, you're going to be behind your patient. Most of the time, if it's a small patient, child, you can use a linear probe most of the time to get through a lot of the tissue of the back muscles in the shoulder. You're going to have to use the curvilinear probe, which kind of penetrates deeper into that joint. So patient, you're going to be behind the patient. The patient is going to be kind of sitting with supination of their hand. They rest their hand on their thigh like this, and they're coming from the back. And you're going to orient your probe kind of whatever makes sense. Most of the time it's, we say to the patient's right shoulder, but if you're looking at the ultrasound and the patient is here and you want to have it to the left because it makes sense for you, then I think you should probably just do that instead of following dictated where the probe marker should be. So in this picture, probe marker would be to the left, to the patient's left, to your left, and then you're looking at the ultrasound probe and you kind of see everything in line. So your humeral head is going to be off to the right side of the screen. And that just kind of makes sense. Yeah. So here you're behind, you're gonna find the scapular spine. And then you're just gonna follow that until you see the anatomy of the GH joint. And this is gonna be what you're gonna see. So what we're really looking at is the glenohumeral joint. You're gonna follow that scapular spine out until you see the humeral head. This is the fossa, and then this is pretty much going to be the end of it. So that's the last thing you're going to see as you move away from the patient's midline. Here's some muscles which you don't really have to pick up on unless, again, you're looking for rotator cuff pathology. And you're just going to look for disruptions in the tendons. Keep in mind your property of anisotropy, where the tendons are going to take on different reflective points as your beam from ultrasound changes and reflects off of them. It's just easier to miss or wrongfully diagnose or tendon pathology. If you see maybe an effusion, but your ultrasound is just pointed the wrong way, then you just have to rotate a little bit and there might actually not be an effusion there. It's another thing to keep in mind when you're ultrasounding tendons. Next view we have here, courtesy of JFK. Thanks. This is the GH joint. The red is the rotator cuff, green is the head, and the purple or the blue is the inferens spinatus, tendon and muscle. So we see internal external rotation of the arm is moving that shoulder and its joint, and that's normal anatomy. So we're seeing the shoulder and the scapular spine in line here with the muscles attached, everything's moving, everything's right in a line. That's good anatomy right there. Yeah, can someone set the mood for us? Is it over here?
Right.
This? Big red button? No, it didn't work. No. All right, we'll keep going. I think this one's supposed to move, but it's not moving. Oh, no, so this is the right shoulder. So you're seeing your scapular spine. You kind of have to make this one up in your head a little bit. It's a little confusing. There's some better pictures here, but this is your humeral head down here. So this is going to be consistent with an anterior dislocation. So again, your probe, curvilinear probe is going to be here, and your glenohumeral joint here, humeral head here. So it's farther away from the probe when it should be. And if you're at the posterior aspect of the patient, it's farther away. That means it's going to be an anterior dislocation. Does that make sense? It's not intuitive, but ultrasound. All right, so this one is actually subluxation of the humeral head. So you kind of see it slip in and out. So that's going to be humeral head. This is probably supraspinatus. This is scapular spine. This is the fossa right here, and we kind of see it slip in and out with external rotation. So as you move the patient like this, shoulder pops out, probably move it back, and it goes back. Same thing again. I think this was a reduction attempt, but same thing, we can call it subluxation too, because the video is just together. But you see the humeral head anterior dislocate from the scapular spine in the fossa. Cool. Who did that? Thanks, JFK. All right, next one. This is actually going to be a posterior dislocation. So here with the arrowhead, we see the humerus. It's going to be closer to the probe, so that's actually going backwards, which is consistent with posterior dislocation. Most common cause of posterior dislocation is going to be seizures. Second most common cause is going to be lightning strikes. I'm just kidding. And again, they measured this one, but we don't really need to do that. Any questions on shoulder dislocation? It's quick and easy to, I'm sorry?
What are the operating characteristics?
Do you mean like the logistics of doing? 100% in the first study that I showed. That's what the study showed. This guy right here. For dislocation, 100 and 100. I didn't really look at too many studies and go over statistics. I more wanted to focus on the operation of diagnosis. However, in the brief ones I did, it reached 100.
Also, I always worry about the fractions. And you know, there's a fraction.
So you can see disruptions of the. Sure. So you would argue that you want to get an X-ray before you reduce. Okay, so you can see disruptions of the bones on ultrasound, but I guess if you have a high clinical suspicion, then you would just get that X-ray.
Actually, look at part of the fracture. As you only to one section,
Mhm.
you have to go down the shaft and.
Sure. I mean, if you have a clinical suspicion for a mid-shaft humerus fracture, you'd probably just get the X-ray anyway. And
At least my research about ultrasound being validated to take onward fracture for its deeper, but I definitely would argue don't use it for that purpose. You know, you're taking clinically. So the patient who has had multiple dislocations, terminal shoulder laxity, went for a layup and the shoulder popped out. Yeah, it's not really a mechanism to worry about fracture, so I don't really need an extra part. Whereas that patient fell down flight of stairs, well, yeah, I'm gonna use the whole of this ultrasound and say, it's okay, let's go back in or get X-ray, because I'm worried about some of the problem. So this is very helpful in terms of.
Are you saying that we should get a history and do a physical exam before deciding who may or may not have a fracture?
I say, well,
That sounds crazy to me. What about posterior dislocations? How is ultrasound looking for that?
like that.
No, I mean, what are the operating characteristics of that?
Or sensitivity specificity, I would assume they're very similar to anterior, but I didn't look at any studies.
That's not enough of that inside. They're very rare.
It's not a lot of lightning strikes. that pop in.
usually very easy to appreciate.
All right. Any other questions on shoulder dislocation? So nerve blocks, there's a few of them. I have looked at some studies that compare the procedural sedation versus just a nerve block. The efficacy is about the same in meta-analysis that we're going to look at for success of reduction between conscious sedation and intra-articular block. So you can do intra-articular. You can also do block to brachial praxis, interscaling, which is going to anesthetize your upper arm, including the shoulder. If patient gets pain relief from that, and they're not too anxious and tightening up, then you're going to have most likely a good outcome for reducing that shoulder. So the technique here with ultrasound is going to be very similar to actually diagnosing with the dislocation itself. Again, you're going to be posterior to the patient. You're going to have that probe marker, however oriented that makes sense for you. You're going to follow the scapular spine to the glenohumeral fossa. You're going to find that dislocation. Then you're going to actually inject your lidocaine or hydrodissect right into the space. And you're going to do that sterilely. So here's a picture. So again, the shoulder dislocation is here. You have that it's the left shoulder, so you want the shoulder to the left. And then you're just going to inject into this space right here, which is the GH fossa. This is looking at normal anatomy again. GH fossa here. I'm sorry, this is a dislocation. You're going to inject right here, which we'll see on the next slide. So on ultrasound, you're going to follow that spinal needle. I forgot to mention that. Probably use a longer needle, especially with bigger patients. Follow that into the GH space, hydrodissect, and then inject your lidocaine. This is that meta-analysis I was talking about. So efficacy for achieving that reduction is just about the same compared to conscious sedation. And this study showed that it does reduce emergency department through times. Right. And then on the last few slides is the interscaling brachial plexus block. And again, it's just going to be that upper arm into the shoulder. So you're going to find your landmarks in the upper section of the neck. You'll look for your IJ, should be hopefully pretty big. And then you're going to fall over to the anterior scalene, middle scalenes, and hopefully right between that, you're going to see the brachial plexus, which is your stoplight sign. You're going to follow it up and down until you see 1, 2, 3 on top of each other. And then you're going to hydrodissect there and hopefully bathe all of those nerves. So here's that spinal needle coming in. Here's your kind of wonky stoplight sign. Mickey Mouse, I guess. And then you're going to bathe that area and hopefully provide the patient some relief. The full exam, but Carly, I think we're about out of time, right? 10 o'clock. Carly, you good on time? Stop here. Okay. So going through the full exam in 4 minutes. So you're going to obtain multiple views of the shoulder. This is mostly going to be for that rotator cuff pathology. You're going to be looking at disruptions of the tendons and effusions inside the tendons, which kind of clue you in, and then larger effusions around the joints. You're going to start with the long head of the biceps. Most of the time with biceps ruptures, if they're partial, it's going to be a little bit harder to diagnose clinically. If it's a full rupture, you're probably going to see that Popeye sign. But if you need to use the ultrasound, you're not going to see that. So you're going to follow it. You're going to see this is the biceps tendon right here, sitting in that bicipital groove. Excuse me. You're going to see anisotropy of the tendon here, and any disruptions of that or swelling around it can clue you into a tendon rupture. And here's that in long axis view as well. It's a good looking tendon right there. You can see all the fascicles. Next one, subscapularis. Here's the kind of view. Right here, you're going to have them externally rotate. It's pretty much what you did for the posterior side for shoulder dislocation. You're going to do that on the front. That's pretty much it. You're going to follow that subscapularis. See that here. And B, you can see all the fascicles of the tendon. It's a pretty cool view. Next one, supraspinatus. You're going to have the, forget what they call the sign, CRAS position, where you take your hand and put it in your back pocket, essentially. And then you can, you just put the probe anteriorly on the humeral head. Follow that supraspinatus tendon. There it is in short axis. And then the last two. And then you can also evaluate the AC joint for widening if you're concerned about a fracture here or dislocation. Those are my sources. Any questions?